Assalamu alaikum, everyone. Am I audible?
Walaikum salam, yes.
Okay, welcome to the Neurosurgical case room after the weekend. And let's start with the parasagittal meningiomas from Mifty. And we are going to cover the relevant anatomy today, along with probably some venous drainage and etc. And let's see how much we can cover in today's session. And tomorrow we are going to look into the detail of the meningioma itself. So without any further ado, moving on. There seems to be a certain confusion in the residents between what exactly is a parasagittal meningioma and when it is a convexity meningioma, when it is a falcine meningioma. So let me draw a very simple illustration to make it easy to understand. This is a coronal section, okay, and these are the cerebellar hemispheres. Ignore the dural layers. Let's draw it like this. And then we have this sinus here, right in the midline between the two hemispheres. And then we have the bone here. This here is the bone. So I'm going to draw three meningiomas, in fact, and this is one. Then we have another meningioma, which looks sort of like this. Maybe reaching up to the bone, filling up the space. And then we have another meningioma, which is, let me choose a nice color, which is going to look like this. We have these three different sets of meningiomas. Now, if I'm going to ask you, do you think this one will qualify for a parasagittal meningioma?
No.
No.
What about the orange one?
Also no.
Also no. Okay, what about the yellow one?
Yes.
Okay, so there is when the meningiomas are huge and when the tissue planes are not as easily visible, a lot of residents, especially the junior ones, they confuse between a parasagittal meningioma, a falcine meningioma, and a convexity meningioma because they can have overlapping features and overlapping radiology. But for any meningioma to qualify as a parasagittal meningioma, it has to fill the parasagittal angle, and the parasagittal angle is on this portion. Let me clear this thing up. So this is the hemisphere, this is the sinus, and this here is the bone, right? It looks more like a uterus, but ignore the drawing. So the parasagittal angle is going to be this portion, this area. So this green thing between these two red lines, this is the parasagittal angle. If this is filled completely with the tumor and there is no, okay, yes, Dr. Motasam, what do you want to say?
What about if the size occupying all the spaces in parasagittal and falcine area? Can we actually differentiate between them practically or theoretically?
No. This is purely a theoretical definition. There will be meningiomas who would look like this. I get what you're trying to say. For example, if this is a meningioma, where are you going to place it? This is exactly what you meant, right?
Yes.
Then we will still have to look at its involvement of the superior sagittal sinus. Any meningioma that is involving superior sagittal sinus should ideally be qualified as a parasagittal meningioma. It can have a falcine component that we will address during the surgery. And yes, the technique would be slightly different than a normal simple parasagittal meningioma. But as far as I know, it would still be qualified as a parasagittal meningioma with a falcine component maybe. So for any meningioma, that fills the parasagittal angle, this space here, which I'm marking right now, without any intervening brain tissue between the tumor and the superior sagittal sinus. That will be ideally defined as, the topic we are discussing. Let's move to the next slide. This is a coronal section. It's a cross-section of the superior sagittal sinus, the hemispheres, and the meningeal layers that we usually look at. Yes, Dr. Fatma, dural attachment would be the ideal piece, to identify the origin, but there will be times where you won't be able to find a proper dural attachment. It will not be as visible. Let me mark this. So we have the cortical surface here, then we have this is the pia, then we have this arachnoid. Between them, we have the arachnoid bridges, or these are this is the space where the vessels run. Then you see these veins, these cortical veins that are going up and terminating into these dilated bluish structures which are surrounding the superior sagittal sinus. So on the cross section, on the coronal section, you will identify this is the actual superior sagittal sinus, and then there are these dilated channels around it, which are also called the lacunae or lateral lacunae. I'm sure most of you would be aware that these are nothing but, sinusoidal channels, dilated veins, which surround the superior sagittal sinus. They are most prominent around the coronal suture and, 2 centimeters, within the 2 centimeters of the coronal suture. I'm sure all of you would have experienced this particular scenario in the surgery where you are very close to the midline doing a craniotomy, but you are very sure that you have not hit the sinus, but there would be profuse bleeding at times, which would look venous in terms of how it is behaving. So that usually is not the bleeding from superior sagittal sinus. That is bleeding. A lot of times it is from the lateral lacunae, especially if you're working anywhere around the coronal sutures. Let me clear and let's move on. So this is an easy example of how a parasagittal meningioma would look like. You can see that it is pushing the cortical surface away, whereas it is also attaching, somewhat invading this portion here of superior sagittal sinus. But this is a relatively straightforward example. This is the concept that I have already discussed, but let's go over it briefly. You know where the Falxine meningioma is going to be, you know where the convexity meningioma is going to be, and you know where the parasagittal meningioma is going to be. And yes, dural tail would help us in determining the origin, but it is not always visible and it is not always specific either. Besides, if a tumor is invading or infiltrating the superior sagittal sinus, you will have to employ specific techniques to have successful resection from the superior sagittal sinus, if it is anterior or if it is posterior. If it is middle and you are in your early career trajectory, probably a better idea is to leave the residual tumor in there, even though, textually you can get the residual tumor out. Are we all on the same page, or am I going too fast? We're good, right? Okay. So the relevant anatomy, which is relatively simple, there are only 2 or 3 things here. We know that the superior sagittal sinus is divided in 3 groups. We have 3 groups or 3, anatomical localizations. We have the anterior, the middle, and the posterior superior sagittal sinus segment. The anterior segment is from, can somebody remind me, please? Anterior is from? Can anyone turn on their mic? It was a very easy question.
Dr. Cole, I think it's from the prefrontal till the coronal sutures.
Okay, anterior is, yes, anterior is from crista galli or glabella from the coronal sutures, right? Depends what marker you are taking. If you are taking it from inside, then cristagalli. If it is from outside, then glabella. 2, coronal sutures. What about the middle portion? That's easiest. The coronal
Yes.
suture.
That
2,
that's between the coronal to lambdoid sutures, I think.
2, lambdoid.
Lambdoid.
That's right. And then we have the posterior. The lambdoid 2.
To the confluence of sinuses.
That's right. Lambdoid 2, the torcula or the confluence of sinus. So these are the 3 segments. And why are they important? They are very important from the surgical point of view in terms of how much of a compromise we can do, how much of the structures can be sacrificed. The anterior portion, we are very clear, it can be sacrificed, even though there are 2 schools of thought. There is a school of thought that says it's okay, you can take it away, you can ligate. I have ligated it countless a number of times, and it hasn't resulted in any problems, sort of, at least in the short term. But there is a very strongly growing school of thought which has started gaining some traction, that if you sacrifice this portion, this anterior portion, anterior to the coronal suture, let me mark once more. If you end up sacrificing it, what ends up happening, patient can go in the frontal lobe syndrome due to venous engorgement. But then again, would depend on a particular patient's venous outflow. We are going to talk about the middle portion later because we know that it's not compromisable. Posterior one also has 2 schools of thought. There's one school of thought that says you can sacrifice it without a lot of problems in the patient. But there is another school of thought which says patient can have homonymous hemianopia. Patient can also have a lot of other problems because, the posterior portion also drains occipital cortex and posterior parietal cortex. The best approach surgically is to not sacrifice it as much as, save it as much as you can, even the anterior segment of the superior sagittal sinus. But there would be cases where you won't be able to do so. Apart from that, you can now also see the lateral lacuna. This is an illustration, and under it you have this dissection or cadaveric image, which has these polymers inside. You can see how big the lacunae are, and especially around the coronal suture. So it's going to be huge around this. Let's move to the next slide. Okay, so these are the cadaveric images, just so it's easier for you to identify. Anterior, we have already discussed. Posteriorly, we have this torcula, and between the torcula and the lambdoid suture, this is the posterior third of the segment. And you can see how beautifully it is visible. The one side of the transverse sinus is dominant, and the other side is, you see, it's not as big in the size. You can see the arachnoid granulations. How do arachnoid granulations appear on MRB, by the way? Can somebody let me know? How would you identify?
Can you please ask the question again?
Okay, how would the arachnoid granulations be visible on an MRV or, an MRI? How would they look like? Can you see them? They appear as filling defects, something which we call filling defects. So you will see these hypo-intense regions within the sinus. Could be superior sagittal sinus. Sometimes they're also visible in transverse sinus. It depends on a particular patient's anatomy. Okay, somebody is... No, not phlovoids, Dr. Hira. I am not sure about the phlovoids, but they do appear as filling defects. I have a few images. Let me see. Okay, so this is the image. You can identify here this hypointense region around the superior sagittal sinus. And apparently this looks like lesion, but this is not a lesion. This is an arachnoid granulation, which is visible as a filling defect. A similar granulation is also visible in this straight sinus. And if somebody is not aware of these, they might end up thinking that something is wrong with the sinus itself. So let's go back. Are we all on the same page?
Yes.
So we have already discussed the superior sagittal sinus and the thirds, the rule of the thirds. We have the anterior third, clavilla to coronal suture. We have the middle third, coronal suture to lambdoid, and we have the posterior third, lambdoid to torcular. The anterior segment is notorious for having a smaller caliber and less critical afferent drainage. But again, this is the school of thought that I was discussing before. There will be situations in which, if you end up ligating it, it might result in a frontal lobe syndrome. Patient can have personality changes. Patient can have akinetic mutism. Patient can have cognitive slowing, abulia, etc., because there can be frontal venous congestion, especially if other venous channels are not patent, etc. So let's move. The middle third is the highest stake zone. We know this already. It receives the Rolandic venous grip. We are going to discuss the venous grips. This is a different classification. The classification that is in MEFT is very different for venous grips, but we are going to discuss them. So the middle third receives the vein of Trollard. We all know that. The superior anastomotic vein, which drains primary motor and sensory cortices. So this is a no-go region. And if we end up sacrificing here, patient can have venous infarction, which is going to be catastrophic, resulting in significant neurologic deficit post-op. And the patient could have severe edema, contralateral hemiplegia, etc. So move. The posterior third is, okay, I have not mentioned homonymous hemianopia here, but if you take away the posterior third, homonymous hemianopia is also one of the consequences. Can have intracranial hypertension, severe bilateral visual deficits can happen as well. And at times, coma or altered level of consciousness can happen as well. Always remember that patients are going to have different venous drainages depending on their own critical anatomy. Venous drainage is variable in a lot of patients. When you would start taking notice of it, it's variable. Apart from the middle third, I'm talking about the anterior third and the posterior third. Do you want to say something? Please keep yourself muted. Okay, so this is a coronal section again, showing us anatomy. It shows some bridging veins. It shows the parenchymal veins and the superior sagittal sinus, the arachnoid granulations, the lacunae, the same illustration that we have discussed before. There is only one important thing that I wanted to note here. I will show the image later on in the presentation, but let's see. So the veins, the draining veins, they enter into the superior sagittal sinus at an acute angle. Why is that important? It is important because that acute angle works like a valve. We know that the veins are valveless structures, especially the sinuses. So when the veins are ending into it, if there is an acute angle, retrograde flow into those veins is very less likely until unless there is a pathology. These are the lateral lacunae, and let's look at the venous drainage here. We have covered the venous drainage before in different sections that we have covered, frontal lobe anatomy, Sylvian, etc. But I decided that was probably a good idea to include that as well. You see the superior sagittal sinus here, and you also see the inferior sagittal sinus here. Along with the inferior sagittal sinus, both of these would be connected with the straight sinus. And all of this is ending into the confluence of sinuses or torcula. Then these are the transverse sinuses. What is important here is, let me change the color. So there is this superior sagittal group, which is which ends into the superior sagittal sinus directly or into the lacunae. This is one group. Then there is another group which works in connection with the superficial Sylvian vein or superficial middle cerebral vein, and that goes somewhere around here. You see here this sphenoparietal sinus, and somewhere here we have the, change the color so that you can see, we have the superficial middle cerebral vein here as well. You all remember it, right? That superficial middle cerebral vein or superficial Sylvian vein drains into the sphenoparietal sinus, goes anteriorly. That is another group. We have a third group, which is connected via the superior anastomotic vein, which is the vein of, can somebody name it? I'm just making sure you're not sleeping.
Then
Okay.
crawler.
That's right. That is the superior anastomotic vein. And this is another group. This is the third group. And then we also have a medial group, which ends into this inferior sagittal sinus and the straight sinus. This is the fourth group. So there are four main cortical groups which are draining all these surfaces and the deeper structures. Why is it important? Because we do not want to compromise any venous anatomy. Let me move to the next image. So this has the acute angle that I was talking about. You can see that the vein, this is the superior sagittal sinus, and this is the bridging vein. And you see it is entering the sinus at an angle, and this angle is an acute angle. If you remember, this was a 90 degrees. This was an obtuse angle. I can't believe we are going over the geometry again. This was an obtuse angle, and the first image that I drew, this is an acute angle. And why is it important? Because this is going to prevent retrograde flow. Because this vein is going in this direction and the flow of the blood is in this direction, it's a lot less likely that the blood would go back into these veins, until unless there's a DAVF or a pathology which is changing the normal flow. So this is important. Apart from that, if there is a tumor going in between here, these veins are automatically going to get pushed either with the surface of the brain or with the bone. So when you are operating, it would be really, really important to maintain the arachnoid plane and, to preserve as much vessels as you can, because a lot of these would not be feeders. A lot of these would be vessels in passé, which, just pass. How do we know that? Any vessel which is just going like this and you cannot see the end, it's always a good idea to identify the second end. Then there will be vessels that will make this hairpin loop. So before coagulating and before using your bipolar, you have to be very, very, very careful regarding what you are coagulating, especially when you are doing parasagittal surgeries. Let's move.
Dr. Cole, I think
Okay.
you can clear the concept of the in-patient vessels again. You said if both of the ends are visible to us, so probably that would be an in-patient vessel.
Yes, it would be.
All right. And what about the surface vessel? That is the feeders.
So there will be three vessels. If I draw that again, let me draw this. There usually are three different types of vessels.
Okay.
Imagine that this is tumor, right?
Okay.
And there will be a vessel which would look like this. This is an en passant vessel or a vessel in passage. Then there will be a vessel which will be making this hairpin loop, right? Both
All
of
right.
these are not tumor feeders. Be very clear. Both of these are not tumor feeders. However, the tumor feeders going to look like, the tumor feeders are going to look like this. Let me draw it. It's going to look like this. They are going to be end arteries. You won't be able to identify the other end. And
All right. The tumor feeder vessels will can either be like deep into the tumors or on the surface as well, right?
yes, once the lesion, once the vessel is entering inside, you have to make sure that there is no hairpin bend out of your field of vision. This could easily be a hairpin bend vessel, which you end up coagulating, and then the patient might have a problem later on. Usually this occurs when you have what do we call, when we have encored the tumor and we are reaching around the base and we are trying to separate the capsule. Usually this problem happens around that region where we are deep in the pit. So you have to be very careful when you are coagulating.
Yes, exactly.
Bipolar is your best friend, but bipolar is also your worst enemy. And I think I keep saying it again and again. And anybody who is in their early stages of neurosurgery, their consultant life, they would agree with what I'm saying. So you have to be very careful with the bipolar, and especially any vessel that is going to give you a clear arachnoidal plane. The tumor feeders will not give you arachnoidal plane. They will breach it. If a vessel is giving you arachnoid plane, you have to maintain meticulously. Meningioma surgery is all about the arachnoid. If you maintain it, you are good to go. If you breach it, then you are going to be in the problem, and patient is also going to be in the problem, because there will be a lot of cortical manipulation, and postoperatively patient will have huge amount of edema. So we have discussed the venous displacement before, that the bridging veins will be displaced, and we know that. Apart from the bridging veins, we have the collateral circulation as well, but let's come to it on the next slide. Arachnoidal plane is just what we discussed right now. This is your single biggest GPS in terms of meningioma surgery, because meningioma is an extra-axial lesion, and a lot of times patient will not have a deficit preoperatively, and during the surgery you are 100% sure that you have not damaged the eloquent cortex, but patient would still develop postoperatively some neurological deficit, especially if you are working around the motor cortex. Why is that? That is because of excessive cortical manipulation and postoperative edema, and because the planes were not maintained. So you have to maintain the arachnoid plane. The capsule will be out of it until and unless there is pile invasion. But if there is pile invasion, there will be telltale signs on the MRI. We have discussed them in a previous session. Can somebody tell me the signs of pile invasion on an MRI?
Edema.
Yes, and?
Extensive edema, and
You won't be able to see the CSF cleft sign. I believe Dr. Mustafa asked this question. And it was a really good question, because the CSF cleft would be affected. You won't be able to see it clearly. There will be extensive edema. Interestingly, since we are discussing parasagittal meningioma, the likelihood of patients having atypical variant or an anaplastic variant is a lot higher if the location is parasagittal. It is higher. I don't exactly remember the percentage, but it is higher than meningioma being elsewhere in the brain. So when you are operating the parasagittal meningiomas, you have to keep that in mind as well. Let's move to the next image. We are running out of time. Collateral networks are really, really important. Why is it important? It might be not of paramount importance if it is anterior segment, but if it is middle segment, and you have a tumor which is invading the superior sagittal sinus, then you want to get an angiography. You want to be sure that there is some collateral network if you're planning to manipulate the sinus, and take the tumor out and resuture it or repair it, etc., whatever your surgical plan is. Collateral network is going to be a lifesaver in these cases, even though I would still recommend If you do not have expertise in the neurovascular domain, then don't attempt taking the tumor out from the sinus. It's not worth it. I genuinely don't believe it's worth it. You can always send that patient to SRS or radiotherapy. So, collateral networks we have already discussed. These can be the meningeal veins. These can be the parasagittal bridging veins, etc. And even though, let's discuss this during the superficial venous groups. So this is the superior sagittal group. The territory is superior aspects of both the medial and lateral surfaces of the frontal, parietal, occipital lobes, some portion of the basal frontal lobe as well. All of these terminate directly into superior sagittal sinus or into the lateral lacunae. We discussed this. Let's move. This is another illustration showing the same thing. So these probably would be considered as the superior sagittal group. Let's move to the next one. We'll come back to that picture. Then we have this sphenoidal group, primarily inferior frontal lobe. We discussed this while we were discussing the temporal lobe and the Sylvian fissure. Sphenoidal group is primarily inferior frontal lobe, anterior temporal lobe, perisylvian cortex, superficial middle cerebral vein is, if you know what drains this space, empties into sphenoparietal sinus. Let's come back here and you can see this vessel here. Mark this green thing. This is the superficial sylvian vein or superficial middle cerebral vein, our favorite vessel since the sylvian, and we know that this curve here is going to end up around the sphenoparietal sinus. Sometimes this also drains directly into the cavernous sinus. That's rare, that's a variant. The normal anatomy is that it will drain into the sphenoparietal sinus, and then the sphenoparietal sinus will either go into the inferior petrosal or cavernous, depending on that patient. Let's move. We will keep coming back to this image. This is the sphenoparietal sinus, and since it shows the deeper drainage, you won't be able to see the superficial sylvian vein here, but we can see it here. We know that this is the sylvian. Somewhere around here, we have the sylvian fissure, and this is where the vein travels, superficial sylvian vein, then ends up into this sphenoparietal sinus, which connects to the subcavernous sinus. Then we have a tentorial group. Tentorial group is also connected to the superficial sylvian vein. If we look at it, let's go back on this image. So this is the same superficial sylvian vein. It goes back, and we know there was an inferior anastomotic vein as well, which is the counterpart of the superior anastomotic vein. This is vein of Labbé. It connects this superficial sylvian vein to the transverse sinus, which is obviously around the 10th. So this is the tentorial group. Let's color code all of this now. Clear all of this. So we have this green thing. Which group would this be? This will be superior sagittal group, right? Are we all clear?
Yes.
Okay.
Kamal, there was a question in my work exam that how many vessels, I mean, the veins are there draining into superior sagittal sinuses.
I'm sorry. Can you repeat your question?
Yeah. In my work, they asked me a question about the drainage of the superior sagittal sinus. That how many veins, I mean, the cortical veins are draining into the superior sagittal sinus.
I do not remember the exact number, but there is a number given in MEFT. I think it is around 8 to 10 in the anterior portion. I am not clear, but there is an exact number. I will look in the MEFT again and write the exact number on the WhatsApp group. Is that okay?
All right. Thank you.
Okay, so this is the superior sagittal group, right? And then we have this is the Which group was this? Can somebody mention which group was this?
Group, I think it's a
Uh,
phenyl group.
This is the sphenoid group, right? And then there is another group. Let me change the color. Which is draining into the transverse sinus, portions of the temporal lobe, portions of the posterior parietal cortex, is going backwards. Which group is this? This is tentorial group. Right? And then there is another group, which is medial, and we cannot see it in this image, but it is the medial group, and it drains the deeper structures into the inferior sagittal sinus, goes back to the straight sinus. We have discussed that group in a previous illustration. It's not visible in this one. Let me clear all of this. You can see just the beginning of the straight sinus right here somewhere, but obviously it goes deep inside. Straight sinus, then vein of Galen, etc., etc. So we can't see it. Let's move to the next image. We have the Falx group, which is the medial group that I was talking about, and it drains the medial surface, portions of cingulate gyrus, corpus callosum, etc., terminates into inferior sagittal, then into the straight sinus. We will continue this tomorrow. I know we have not even started the parasagittal meningioma, but you cannot cover it nicely if you're not clear about the venous anatomy and the groups, etc. If we have any other questions, please let me know, apart from the exact number of the veins.
No, I think it was great. But my question is that in the next sessions, what are we like? What will we be discussing? Is it the surgical nuances or the
We
tumor?
will see how much we can get along, because there is only a limited amount of time, obviously 30 to 40 minutes. And in that, I would like to cover the classification, the radiology, and at least some of the surgical nuances. If we are not able to complete the surgical nuances completely, then we would keep a separate session on it. There is no rush.
All right, thank you. I
Okay,
think that's
thank you
great.
so much, everyone. Thank you for the yes, classification we are going to do. We have two different classifications in the Sindou, and then there's a Radiology classification something. So we will discuss it in tomorrow's session, inshallah. Thank you so much, everyone, for joining. This is to be continued. It's not a wrap. Thank you so much.